So, Bob, we have some emails here. This first one is about touch in therapy. Shall we go over it?
Let's do it.
This is the Psychology in Seattle podcast. I'm your host, Dr. Kirk Hanna. I'm a therapist and a professor. Who are you, Bob?
I'm surprised we're doing this. My name's Bob. I'm your good friend from graduate school from 100 years ago and a therapist here in practice in Seattle.
That's right. Anonymous listener, she says, "Hello, Kirk and Bob. I have a question regarding physical touch in therapy. I'm 25 years old, and I was diagnosed with borderline personality disorder, by the way. I've been seeing my current therapist for over a year now, and over time, we've been able to build a trusting and safe relationship. Okay, I've been seeing my current therapist for over a year now, and we have a good relationship. We have a very close therapeutic bond, and it's new to me. I still often struggle with intense feelings of shame and sometimes fear, but I'm now able to talk more and open up. I have strong, warm feelings towards my therapist and eventually gathered the courage to tell him about these feelings. We've talked about transference and also discovered that for me, feelings of love are closely linked with shame and guilt. When I feel that way, I sometimes long for comfort and want to hug him. For the past few sessions, we've occasionally sat next to each other, and he has held me for a while and gently stroked my arm or shoulder. For the past few sessions, we've occasionally sat next to each other, and he has held me for a while and gently stroked my arm or shoulder." Okay, I'm trying to envision that. A while, what is that? It sounds 5 minutes, 10 minutes or something. I don't know.
Yeah, I don't know.
This feels very soothing and comforting, and it has helped reduce my self-hating thoughts. However, I'm afraid to move during those moments because I don't want to do anything wrong, and I often feel very dazed afterwards. I also worry that my feelings of love might intensify and that I could become too dependent on him. I don't want to want too much, and I don't want to be too much. My question is, when is physical touch in therapy okay and when is it not? What are the potential benefits and especially the potential risks? Thank you so much for the amazing work that all of you do." End of email. Bob, what do you think?
Yeah, this is a great email. A bit provocative to me. So one of the things that you're talking about that I really appreciated is that you guys are deliberate in the way that it sounds like you're deliberate in how you use affection in your session. And I don't know if this is true, but it sounds like your therapist is really mindful of their impact on you. And you guys have what I think is a good basis to keep talking about this. So what I hope you'll do is you'll say, that you freeze when you feel your therapist's arm around you. I'm presuming that you want to have their arm around you and that you guys are clear that this is part of what's therapeutic, like a corrective experience of affection and care. And you're having what I would call probably a pretty typical response if you've got a trauma and abuse history of freezing. So talk about it. Definitely talk about it. And you guys might actually play with moving. Like, let's just move. We can just move. We can come back to this. We can also just move again, right? To kind of help you, shift your nervous system maybe a little bit, or teach your brain that it's actually safe to move. Just because someone's arm around you doesn't mean you got to be frozen and still. And I'm guessing, though, I don't know if this is true, that your therapist is managing their feelings that are arising. So the chances of you being too much aren't maybe not that great. Though the fear of being too much is probably pretty typical for those of us who have this kind of stuff. And let's see. And then there was one more thing.
Well, would you ever do this kind of work as a therapist?
I get scared. I think because of my own stuff, I get a little bit scared, but I've done some small amount of that. Yeah.
Like what?
I think I held hands with a client once who was going through some really hard shit. We talked about that. That was what I was going to do. And I sat next to them, and they were immersed in some pretty heavy duty trauma exposure.
Was it a woman?
Yes.
Were you afraid of being sued or something?
No, not being sued. I think I was afraid of would my colleagues think I was, fucking up, and I was afraid that I might be seen by my client as having some kind of, motive beyond care for her well-being.
Yeah.
Which I mean, that client was very important to me. I cared a great deal about her.
But you weren't a perv for her.
No, fuck no.
Yeah. Did you address that at all directly?
Yeah, I think one of the things that I said to her is that I didn't know if I wanted to do this because it was making me uncomfortable. Not because there's anything wrong with what she wanted, but I think it might just be my own limit for whatever reason. Like, I don't feel comfortable with touch like that, and I probably wouldn't do that again.
Who initiated it?
We talked about it.
But who initiated it?
I don't recall.
Okay. It could have been you. It could have been like, do you want me to hold your hand? Is that?
Yeah,
like
it could have been. It could have been that.
Yeah. Yeah. So, in response to your email, anonymous listener, I believe you are, what I'll say is that, yeah, as Bob is saying, it sounds like you have a really good therapeutic situation happening here, and there isn't any overt sign of anything bad happening.
Yeah.
Touch can accelerate therapy and healing in a way that talk can never do. Well, what I'll say is that what we hope for people with relational traumas, like people with borderline personality, that they have significant time spent with their therapist experiencing corrective experiences. And that can be sometimes accelerated by physical touch, physical warmth. But there are risks, right? And that's what you're asking about. Also, if you presented this case on the internet, then everyone would assume that your therapist is a creep and has already sexually assaulted you, if not grooming you for more predation. But it doesn't mean that. It could mean that, but that's not my assumption because that's not common. The more likely scenario is that he is on the up and up, and he has a style where he does that sometimes, and it has been found to be helpful, and he knows that he's not going to cross the line. That isn't to say that this isn't some sort of a grooming situation, but that's not my assumption.
Yeah.
It's sort of like if someone said, I have this friend that likes to hug whenever we meet up, and I'm not very comfortable with hugs, so I don't really know. I wouldn't assume that the friend is a rapist.
Yeah.
It's kind of in that category. Could the friend be a rapist? Yeah, but it's not. But here's the thing, is when it comes to touch and therapy, especially at this level where he's holding you for a while, as you put it, there are ethical codes that are a help in this situation and guidelines. And our general professional ethics don't address this directly for a variety of reasons that I won't go into. But we do have an organization called the United States Association of Body Psychotherapy, and they do provide a code of ethics, and it has been vetted for a long time, and it is researched. But I will look to this sometimes, but the general guideline is also just present in the other professional organization ethical codes, but they just don't really orient it towards the body and the physical and the touch in therapy. But just to go over those principles, one is consent, is making sure that the client is consenting and that there's ongoing explicit discussion of it, like the way you were talking about with that one incident. There has to be a fair amount of odd, because, if you have a friend that is grieving the loss of something and you just held their hand or hugged them, you wouldn't have a 3-minute conversation about the hug before hugging them. But in therapy, you have to have that conversation. And there's a lot of corrective experiences that can happen just from that conversation. It's not an impediment. It's a part of the therapy. It can be therapeutic. Also, the therapist needs to be competent. Well, what constitutes competency in using touch in therapy? Well, on one end of the spectrum, you have a therapist who has never looked into it and maybe never even done it and suddenly decides to use touch significantly. Now, I would say holding hands is not really in that category, as you were saying in your story, because I would say that holding hands is pretty low grade. But if you're going to be hugging your client, then I would say that you need to make sure that you can demonstrate competence. Then there's various different ways to demonstrate competence. I would say that if you sat next to a client, on the couch and maybe your sides were touching and you were holding hands, or you were side by side and you had your arm around the client or something, I would say maybe that wouldn't require a ton of competency, but probably we're getting in that direction. But if you're embracing a client for a while, like the way this therapist is, then I think 99% of therapists would say that you have to demonstrate some sort of competence. How do you get there? Well, the obvious is trainings and that sort of thing. And maybe you are a member of the U.S. Association of Body Psychotherapy. You pay your dues or whatever. That's an obvious way. But I don't believe that that's the only road to competency. You can also gain competency just by studying it, by having a consult group or a person that that knows more about this, or just a practice of consulting about it. Maybe you've inched towards those kinds of experiences and processed them yourself and consulted, maybe supervision. So there's a lot of roads to competency in my view. The other principal guideline is autonomy, that the client needs to feel like they can say yes or no, obviously, throughout the process. The other principle is that the touch is done in a helpful way. It's with the intent of helping, and there's enough justification from the therapist to believe that the touch would help and not harm. Often that has to be pre-thought about and documented. Obviously, that would help and is a good practice to get into. Also, another principle is consultation and possible supervision oversight is always helpful, right? Now, maybe as a therapist, you have a general policy that you have a set group of behaviors that you will use as interventions with clients as a corrective experience. You've thought about it already. This is the hope, is that there's been some pre-thought, some planning, and it's not just something you're doing out of the blue, particularly holding a client for a while. And through that thought process, you've looked into the guidelines, you've consulted, you've read some articles, you've heard some experiences, you have maybe even in your disclosure statement something around this, because it's too much to ask a therapist without having done some pre-thought to be able to check all the boxes before, during, and after an event like this in therapy. This isn't to say like it's this huge event and it's just like this big deal, but it does require that, not, well, partially to cover your own ass, but mainly so that the client is helped the most, right? Like, and the last principle is documentation. So you ask about over-dependency, and as long as he isn't isolating you and harming you, for you to become more dependent on your therapist isn't necessarily harmful. It actually could be helpful. The idea is that through dependency, which you already are to some extent on the therapist, is healing, and that through those corrective experiences with someone that's safe and that doesn't exploit you, you will be able to generalize that experience to your trust of people outside of therapy, and you'll be able to have dependency outside of therapy. That's the idea. And then you will no longer feel dependent on your therapist. So this idea of overdependency is a bit of a misnomer, especially among relational therapists like you and me, Bob. The other thing, one of the risks, though, is that it could be replaying old traumas. And you show signs, as Bob pointed out, that you are freezing. Now, there's another explanation, because the way you describe it, I want to read it specifically. You say that, let's see, very soothing, however, I'm afraid during those moments, however, I'm afraid to move during those moments because I don't want to do anything wrong. And I often feel very dazed afterward. So most people would read that and say that you are dissociative, but it's not entirely the case, or it's not a slam dunk indication. It could be for sure, especially the dazed part. And most people would assume that you saying you don't want to move is this freeze reaction, and is either you're being traumatized in the moment or it's provoking old trauma. But that's not necessarily true, particularly given the way that you're describing. I want to say that it could be that, and this is something you obviously should be talking with your therapist about. But this feeling, the way you describe it, I'm afraid to move during those moments because I don't want to do anything wrong. That is a way of describing it that leads to the very clear possibility that what you're experiencing is actually just a normal part of the interplay of a corrective experience with someone that is safe. So he's safe, and he's providing you this corrective experience, and he's hugging you. Sort of, I don't know. You said holding. You didn't say hug. So it sounds like maybe he's sitting by your side and maybe has loosely. It's like a loose hug. It kind of the way you describe it. And in those moments, you're just like, I like this. This feels very helpful, but I have a lot of shame and I have a lot of experiences from my past, from my childhood, where I would fuck things up and people would become flung away from me, and I would later conclude I must have done it wrong. And so, you're afraid, and you are afraid to move. So it could just be that, but it also could be, or it could be both. It's just a lot of different things. The one thing that I want to say as one takeaway is that all your questions should be answered by your therapist. In fact, your therapist should have addressed these questions before this ever happened, which is a little concerning, I have to say. It doesn't necessarily mean that he's unsafe and that he's predatory, but it could mean that he isn't aware of the guidelines, which raises risks, doesn't guarantee harm, but it raises risks. Body therapists, people who as a routine use touch and therapy, have a whole routine of ramping up to this kind of behavior, this kind of intervention. They will say, here are the risks. Here is what you do if this happens. Here is how it might feel. And there will be explicit conversations afterwards. It won't just be something that is spontaneously done and then never talked about. That's not the way you're supposed to do this. It doesn't mean you have to spend hours and hours talking about it, but, it doesn't take long to ask a question, 30 seconds, So I would, if I were you, I would say, I very much appreciate what seems to me to be a very healing thing that when needed, you do hug me, but I'm worried about overdependency. I'm wondering about the risks. I am also having this experience of being dazed afterwards that I would like you to assess to make sure that I'm not being harmed. Those things you absolutely have the right to ask, and it's a little concerning that he's putting you in the position where you would have to ask, honestly. So that's what I'll say about that. Let's take a break. When we get back, more emails. What do you say, Bob?
Yes.
All right, we're back from the break. Let's do an OPP. So, Bob, in the last episode, you gave me a name like Carl.
I did.
Give me a name. I like that.
Zoey.
Zoey. So Z-O-E.
Z-O-O-E-Y, I think.
Z-O-O-E-Y?
I don't know how to spell Zoey.
No, I mean...
You can't have too many Z's. I imagine if you just pop up the Z's, you'll...
Okay, so I like this because it's always so fascinating to type in... Zoey is common, but not super common.
Not super common.
But when we look at all the Zoes of patrons...
You got a lot of them?
We got a number. So we have, I believe, a Zoe in Annandale, Virginia, who's been a patron for the past 8 months. We have Zoe from God knows where, who's been a patron for a couple years. We have Zoe B, is the first letter of the last name, from Westlake Village, California. Been a patron for a couple years. We have Zoe P from Washington, D.C., which rhymes. Been a patron for a few years. We have Zoe E, who has been a patron for a few years and is one of our top contributors, by the way.
Wow.
Which is very nice of you, Zoe E, from God knows where. We have another Zoe B from Raleigh, North Carolina. I hear that Raleigh, I have a friend from Raleigh, and lovely town. I think it's a college town.
I think so,
Been
yeah.
a patron for 4 years. We have Zoey S., who I believe I've interacted with over email from Melbourne, Australia,
Wow.
or specifically Coburg, been a patron for 4 years. We have Zoey S. from Brooklyn, New York, who has been a patron for 7 years.
Wow.
Actually, coming up on the 7-year anniversary. Thank you, Zoey S. It looks like maybe Zoey has been a patron on and off. Not sure. So thank you to all the Zoes. Let's read another email.
Right on.
Highest tier patron Gabby from Texas. She says, "Hi, Kirk and Bob. I was listening to y'all's episode on Serenity Mental Health Centers." Do you remember when we were talking about that?
Yeah, that place, yeah.
That marketing ad that they had about denigrating therapy and stuff.
Right.
I was appalled to hear about the graphic they posted and agreed with your and Bob's takes. I've been going to therapy for years, and it has helped me more than anything else. So Gabby is saying, therapy is a good thing. I wanted to bring up my experience with visiting them.
Oh.
So highest tier patron Gabby from Texas has been to Serenity Mental Health Center.
Was she undercover?
Huh?
Was she undercover?
No, this is in the past. I did not have any issues with my care and only left because of insurance changes, but something they pushed a lot was transcranial magnetic stimulation, or TMS. I went for ADHD to get tested, and at my first appointment, they pushed TMS, transcranial magnetic stimulation, as something that could basically cure my ADHD with brain waves or something. I had never heard of this. It was kind of strange to me that they pushed it so much. Is TMS a thing you've heard of? Thanks so much. I love y'all. End of email. Bob, what do you think?
Yeah, I've heard of TMS, but not as a treatment for ADHD, though I don't know about that, as a treatment for depression. It seems to me that any good treatment provider is going to make a person aware of what they know to be, out there and available as a resource for healing or whatever, but isn't going to push shit.
Yeah.
Like, why would anybody push anything?
Yeah.
Like, somebody doesn't want it. They don't want it. Fuck it. You know? If you don't think that what you're doing is the right thing to do, then you should say so.
Yeah.
But I've never heard of TMS for ADHD. Have you? I'm not saying that I haven't, that it doesn't. I don't know anything about it one way or the other.
No. No.
TMS is just an MRI. It's a fucking MRI. That's all it is, except they stick to your brain and they run it for longer, I think. Mm-hmm. Yeah.
Yeah. So it's not supposed to be used for ADHD. It's not been demonstrated to help with ADHD at all.
Well, then that's just stupid.
So, yeah. Now, we don't know the pressure that
I'm sure
was being put on her. Maybe it was within reason, but it doesn't sound like the patient was being served correctly. But now I'm guessing that this organization is, for the most part, on the up and up. The individual psychiatrists who work there, I'm sure, are on the average up and up. So I'm not denigrating that, but we do have one experience. So let's talk about TMS because we get questions about it sometimes. So yeah, as you're saying, Bob, it is typically used for treatment-resistant depression,
mm-hmm.
and basically, in transcranial magnetic stimulation, it is the way it sounds. It's transcranial, meaning that you use magnetic stimulation that's targeted and strong enough so that it goes across the skull. There's a bug in my face right now. It keeps flying around my back. And it will stimulate the electrical impulses of a kind of large part of the brain. I mean, we have a really hard time pinpointing these sorts of things. And everyone's brain is different and da-da-da-da-da. So it's pretty ham-fisted, but so are medications, because when you use medication that affects serotonin, like serotonin is used in various ways throughout the body. So it's not any different from that. And it is a viable treatment for treatment-resistant depression. Also, to a lesser extent, for treatment-resistant OCD. It is used for that as well. But basically, it you lay down, and like you said, it's like an MRI, and it is focused on a particular part of the brain, and there's different protocols, blah, blah, blah. And it's pretty low side effect, right? One could argue far less than even SSRIs or other antidepressants. But there can be some temporary problems, temporary side effects like pain on the scalp. You can be lightheaded, or you can have a mild headache or something. Sometimes people have seizures because, you're involving the brain, but that's pretty rare. And some people would actually take a couple seizures now and then to get relief from treatment-resistant depression, because it's no joke. People who resort to TMS for their depression have typically been through 10 years or longer of various different meds and very little relief. The studies show that there's on average about a 35% response rate to TMS for treatment-resistant depression, meaning that about a third of the patients will experience about a 50% or greater reduction in symptoms, which is a pretty big deal.
That's great.
And this is all compared to placebo and sham treatments, because those will also show a response rate. Like you have people, you do the whole thing. You have them sit in the device, but you don't actually turn on the machine, but you act like you turn on the machine. And there is a fair amount of people that will experience improvement just because of that, either because there's just a random uptick or downtick in their symptoms, or they are paying attention to themselves, they're relaxing, they're getting care, it feels nice, and it can cause people's depression to reduce because of that. And another finding, because it's been researched a lot over the past few decades, is that there's about a fourth of people will no longer qualify for the diagnosis eventually, which is a big deal.
That is a big deal.
So that means that it's an absolute viable option. Sometimes it's not covered by insurance, which is bullshit, but it's an absolute viable option for people with treatment-resistant depression. It's a pain in the ass, right? Because it's not a pill. You've got to go into the thing, sit in the thing, and do it frequently. But for the payoff, it's a big deal. Having said that, most people who go through this treatment don't experience much, if any, improvement. So it's a roll of the dice, but worth rolling of the dice if you have life-crushing depression over time. There's a similar usage for OCD, although it's even less, but still significant. Again, OCD can be life-ruining, and if the typical meds aren't working and the typical psychotherapy is only helping so much, you might as well give it a try. There is research currently looking into other disorders like psychosis, bipolar, depression, chronic pain, migraine, stroke rehabilitation, Parkinson's, and PTSD. But for someone, as you're saying, Gabby, to push it severely, especially for ADHD, is extremely problematic, given what I understand. Now, maybe I'm wrong. I'm not a psychiatrist. I don't do this kind of work. But let's move on to another email after a break. What do you say?
Yep.
All right, we're back from the break. I like this game of OPP. Give me another name, Bob.
Belinda.
Is that a B-E?
B-E, I think B-E.
Linda. Belinda. It's a good name. Are there any Belindas? No, not a single
Not
Belinda.
a single one? Okay.
Yeah.
Margaret.
How many Margarets? Looks like there are 5 Margarets. That's a good name, Bob. We have Margaret O. from Washington, D.C., been a patron for about 5 months-ish. We have another Margaret O. from God knows where, who's been a patron for a couple years. We have a Margaret S. from Boulder, Colorado, who's been a patron for 4 years. We have an Ann Margaret from Seattle, Washington. Looks like she might live in West Seattle-ish. Huh. or actually, I won't mention because it's kind of a specific neighborhood, but not far from where we live. And then she's been a patron for 4 years. Thank you, Ann Margaret, local. And then there's a Margaret that goes by Greta from Shoreline, Washington, who's been a patron since 2021. So isn't that interesting?
It's very
5 Margarets.
Greta. I like that name.
Yeah. All right. Next email from Patron Minnie. She says, "Hi, Dr. Kirk and Bob. And Stephanie. Hey, girl." I think that Patron Minnie has a friend named Stephanie that listens to the podcast.
Oh.
So
I was like, is there someone on staff?
no.
No. Okay.
So hi, Dr. Kirk and Bob and Stephanie. Hey, girl. When I was a teenager, I was incontinent for more than 3 years. Just chiming in. Bob, what is being incontinent?
Means when you pee your pants.
Yeah. It was a very shameful and depressing issue to live with when I was a teen. My mom really did her best to help me and get me the care and supplies I needed to live cleanly and unrestricted. But it drove me into a deep depression to feel uncomfortable at school, at sleepovers, and even around the house at one point. Now that I have overcome this issue with medications, lifestyle changes, and physical therapy, I find myself questioning the reason behind why it happened in the first place, because my doctors found no discernible cause. I questioned whether it was my depression and PTSD causing it to get worse, or was the depression a symptom of the shame of being incontinent. Sorry. Chicken and the egg sort of thing. I did suffer childhood sexual abuse, but it was long-term. It was not long-term and severe. Okay. So she's saying, being incontinent could be related to the childhood sexual abuse, but it wasn't long-term or severe. And I was in deep denial at that point in my development. So my main question is, have you ever worked with anyone with an issue like mine where trauma caused incontinence or other embarrassing psychosomatic symptoms in teens? Or is it usually an unrelated problem that causes an increase in mental illness symptoms? P.S. My current therapist, who treated me as a teen, does not know about this because how severe the shame has been for me. So I have processed all this on my own. I really appreciate how you are willing to address issues that many won't touch with a 10-foot pole, and there are very few people who talk about this. I love y'all's podcasts, and I hope you're having a great summer. Patron Minnie. So Bob, have you ever worked with anyone with an issue like this?
No.
Where trauma has caused incontinence or another embarrassing psychosomatic or what we call somatic reaction?
No, not that I'm aware of. No.
Okay.
Yeah.
And what do you think about it?
I don't know enough about the body. I was thinking, just did all this sex therapy training, and I'm just thinking about weakened pelvic floor muscles maybe being a part of the trouble, but I don't really know. And I'll say this. When are you going to touch this with a 10-foot pole? Because you're not talking about it with the therapist. So come on, let's get on that.
Yeah, there's so many benefits. You don't have to. Obviously, there's a lot of other things you could be working on. But
yes, you do. You do have to.
But, well...
I'm kidding.
But the secondary benefit, indirect benefit, is just talking about something that you unfairly are shaming yourself for because of internalized voices, right, and overcoming that and standing tall. Just that, regardless of what the topic is specifically, that's a very healing therapeutic activity. But I will answer the question and say, yeah, it's a common enough symptom of abuse, and specifically sexual abuse, but also just general abuse, that for people that work with kids and teens, that it is kind of a red flag. If we hear about an incontinent kid and we don't know about any abuse, it is one of the questions you will hear in consultation of just like, I wonder if there's some unknown abuse that the child has been through. It's not an assumption and should never be an assumption, but there's that. And given your scenario, yeah, it's a question that we have as well as clinicians that really can't be answered. There can be ways of assessing for this, like if through treatment or through getting away from the abusive person, the incontinence goes away without any other changes, then you're like, well, seems likely it was related to that. But it doesn't sound like we have that luxury of having that variable isolated in that way. And so, yeah, it's possible. It's possible it's both. It's possible it was partially a physical issue that would have happened anyway, and partially a psychological issue, and that the mental issues that are a result of your life, PTSD, as you're saying, and depression was also making it worse, and then through a feedback loop was making your depression worse, and back and forth. It's all there, but it's a pretty common thing, and in fact, I would say anecdotally, if I was working with a teen who was incontinent and had experienced trauma in their past, I would say the vast majority of the time it would be conceptualized as a symptom of the trauma and lesser because of a functional problem with one's pelvic floor, or because of there are other causes to this sort of thing. And it makes some sense, right? Because on the general level, when we're suffering from trauma, we're not often given a way to talk about it, and our body will try to express itself in some way, either to tell the self, hey, something's wrong, or to alert others. Also, it kind of makes sense that if it's sexual abuse, that it would manifest in a somatic symptom of the genitals, of the bladder, of one's, quote unquote, private parts, in this way. So there's that. Also, metaphorically, it can be considered, as one is going through abuse, often there is a sort of letting go of one's body, of releasing control over one's selfhood, right? You just have to, surrender and say, I'm not of my body, or my body is not under my control. And the physicality, even sometimes, of giving up under the intimidation and coercion and control and harm, that your body just relaxes. And it's just, not that you're relaxed, but your body below the neck says, okay, I am now just going to, the way that I can think about it is, if I'm having a medical procedure and I don't like what's happening, I don't even like IVs. And if I went with my instinct, I would resist it, right? At the very least, I would be tense, and that doesn't usually go well. So I have to kind of force my body, even though my mind is freaking out, I have to force my body to sort of become like Jello on a certain level, just let it happen. And that's not anything like sexual abuse, but it's akin in that way. And you could see how that could manifest in a variety of reflexive relaxations, including relaxing of one's bladder control. So there's a lot of different thoughts as to why this would happen.
That could be vagal collapse.
Yeah.
Yeah. So.
Yeah. It also is considered to be a way for the body to protect itself, of ridding itself. Also possibly a way for the body to repel, to say, well, if I'm all soiled down there, maybe they won't attack me anymore.
Right. Yeah.
It's why some abuse victims will try to gain weight as a way to unconsciously or even consciously be unappealing to abusers. So there's a lot of different ways that we think about this, but yeah. So you're saying, have I ever worked with anyone with this issue? I would say, yeah, and other, as you say, embarrassing somatic symptoms for children and teens, let's see, what other kinds of things can I think of? Well, I kind of mentioned them, but also hygiene issues, I suppose, but that's not really the same thing.
And caprices. Right,
and caprices. Also sleep issues, or being incontinent in bed while sleeping.
Yeah.
Yeah, I'm trying to think of other kinds of things like this. It's just kind of interesting that is one of the only ways that your body can express itself in a very clear way,
Like just void itself.
Yeah, because we do it throughout the day, so why not do it in a way that's unplanned, as a way to alert the self and others that something's wrong here, you know? Now, I want to be clear, though, that, you know, you mentioned this childhood sexual abuse, but you're saying it wasn't long-term or severe. Now, that can be enough. So I'll say that. But it's also possible that I could see a lot of people focusing on that and saying, like, well, that's the clear cause. You know, it sounds like your depression and PTSD has a number of causes, and all of those causes could be related. And it could be in addition to the childhood sexual abuse experienced or instead of it. So there's just no way to know is the thing. And then you also ask, is it usually an unrelated problem that causes an increase in mental illness symptoms? Is it usually an unrelated problem? I see. Yeah, it's not usually, like I said, but that is absolutely possible for an unrelated psychological, you know, like you just had a functional issue of incapricis and had nothing to do with your psychology. Could that cause depression and PTSD-like symptoms? Absolutely. Absolutely. I would find that most incontinent teens have some emotional fallout, including depression. I mean, PTSD is kind of specific, but, you know, you could see that happening. You pee your pants in the middle of class, and even if no one found out, like that would leave a mark on one's psychology, so to speak. So, but yeah, as Bob says, what a wonderful thing you could talk with your therapist about. And therapists, generally speaking, are extremely comfortable talking about this because there's nothing more, I don't know, there's nothing more understandable than something like this. Therapists understand this sort of, yeah, makes sense to me, you know. Yeah. And there's nothing to be ashamed of. Absolutely nothing, you know. In our society, we have some really fucked up ideas about what to be ashamed of, and there's nothing to be ashamed. And I'll delineate, you know, that there are situations where we should feel shame, like if you purposely killed someone or a puppy, or you know, you did something on purpose, you knew the consequences and you did it anyway. I feel like being ashamed of that is, you know, maybe why we have shame.
I don't know if you want to keep this in, but I sharted at Costco once.
Tell us about it.
Oh, I thought I had to fart. Walking down the aisle in Costco, turned out, little bonus. And yeah, there it is.
Yeah.
I go to my doc and I'm like, I sharted at Costco. And he's like, what's a shart? So I told him, he's like, oh, that's called rectal incontinence, Bob.
Or incapricis. How much product was produced?
Oh, product. What a great word. I would have called it waste. Oh, not much. Just a little splash.
And you immediately knew?
Oh, well, yeah, because I could kind of feel it. And then I went into the bathroom and discovered, yep.
Oh. And then what'd you do?
I told Colleen and we laughed and we continued to shop.
Did you clean it up with toilet paper and stuff?
I cleaned up what I could and then I went home and took care of the rest.
Yeah. But you didn't immediately go home?
Nah.
Yeah.
Yeah.
Yeah, fuck it.
Yeah.
Yeah. Yeah. Well, thanks for leading the way on that, Bob.
Hey, right on, man.
Nothing wrong
Next
with
time
that.
I shard, I'll let you know.
Yeah. So, 10-foot pole eliminated.
Yeah, right.
And everyone out there, please take care of yourself because
you deserve it.